My name is Brent Keller. I'm one of the gastroenterologists here at Southeast. I've been here for about 2.5 years, and so obviously we're talking about colon cancer prevention, and I appreciate you guys coming out. I know the weather is looming, so hopefully we'll make this quick. I've added some slides about diet and some things like that, so it should maybe run around 50 minutes to an hour, but I'll try to fly through it. But as laid back as possible, just interrupt me and ask questions. I don't mind. Throw something at me if I don't see. It's quite all right. So we'll get started. And this is a couple of ads that I thought were funny. I looked up online. This is actually an ad that's going on in Minnesota right now. There's a better way to get a colonoscopy. Sometimes my wife says my head is in that position a lot. So I thought that was a good one. And here was an interesting one from a few years ago, actually, where this Hansen Center encouraged friends to go get their colonoscopy together. So, and so they would go. At first I thought it was. I read the article. I thought they would drive each other, and then, but actually they're going together to get their colonoscopies. So I thought that was a good campaign. But I like to start with a take-home message, because if y'all's attention span is as long as mine, we may get lost in the shuffle over the next hour. So I like to tell you what I'm going to talk about it, and then tell you again what I talk about. So the take-home message is colon cancer is preventable via colonoscopy. And when you think about all the cancers, prostate cancer, lung cancer, breast cancer, they don't have a precursor lesion. So when we're looking for, when we're doing mammograms, we're looking for actual cancer. So in colon cancer, we're looking for polyps. It's not cancer that we're looking for. By the time it's cancer, the cat's out of the bag, and we're dealing with a whole other animal. So colon cancer is preventable because it starts with a polyp, and it's a precursor lesion. In prostate cancer, breast cancer, lung cancer, it just it starts with cancer. There's no precursor lesion. I think that's an important point to get across. Is it's actually preventable cancer. It's not cancer we're looking for. We're looking for polyps. And so colon polyps and colon cancer do not have any symptoms. They don't. Polyps don't bleed. I've maybe in the 7 years I've been doing colonoscopy, I've maybe seen a polyp bleed like 3 to 5 times. It just doesn't happen. So you're not going to have symptoms from the precursor lesions, precancerous lesions, polyps. It doesn't cause constipation, doesn't cause diarrhea. They're just there. And it's just kind of like a mole. If you don't think about it as a mole on your skin, you don't even know it's there, and sometimes you don't even feel it. And it's the same kind of thing. And even the first stage or 2 of colon cancer is the same way. In fact, Ronald Reagan, as we all know, had colon cancer in 1984, and he didn't have any symptoms, and then started to have a little bit of bleeding. And by the time he was eventually diagnosed, he was already at stage 3, and he just had a little bit of bleeding, and so little bleeding they were calling it hemorrhoids. Polyps don't bleed, and colon cancer, for the most part, doesn't bleed until late stages. And we need to start screening at age 50. That's for most people. The average risk person needs to get colonoscopy at age 50. If you have family history, that changes, and we'll talk about that in a little bit. And of course, the final point is get screened. Over 1 million folks in the United States either have been diagnosed or have colon cancer currently. 140,000, over 140,000 in 2013 were diagnosed, and 50,000 deaths in 2013. It's the 3rd most common cancer worldwide, 2nd leading cause of cancer death in the United States, behind lung cancer. And if you take everybody in this room, one of us, I guess, based on the numbers, are going to be diagnosed with colon cancer, because 1 in 20 of us will be diagnosed. So let's start with the basics. What's the colon? This is it outlined in red here. It's basically, depending on how tall you are, basically it's the last 4 feet of your intestines, and it stores our waste, and you absorb a little bit of water from the colon. But for the most part, it's just a wastebasket. As gastroenterologists, we like to change it into basically 5 organs: the right colon, which is the ascending colon, the transverse colon, the descending colon, sigmoid, and rectum. And so we know over time, over the last 30 years really, that there's different percentages of colon cancer in the right or left colon or the sigmoid colon In the ascending colon, for instance, it's 30% of the colon cancers will occur in that part of the colon. In the transverse colon, only 10%. In the descending colon, it's only 15%. Sigmoid colon, 25%, and then in the rectum is 20%. And the reason this is important is that the surgeries, if you did have colon cancer, per se, then you would have a different surgery based on where it was located. If it's on the right side, you're going to take out that part of the colon. If it's in the middle, take out that part of the colon. If it gets down here in the rectum, actually, it becomes a little bit of a issue of how close it is to the very bottom, towards the anus. It can cause some problems and actually may end up having to have a bag. And these are all things. This is all preventable with colonoscopy. In fact, Ronald Reagan's colon cancer was in the ascending colon at the time. We only did flexible sigmoidoscopies because we didn't think colon cancer occurred on the right side of the colon. So when he was diagnosed, he had 2 or 3 flexible sigmoidoscopies looking at just the sigmoid colon and the descending colon. They kept saying it was hemorrhoids or something else. And then finally, I guess Nancy got to him and told him to do a whole colonoscopy, and they found it on the right side. So he had it almost for a year. So we're doing a better job through programs like this, getting the word out. So colorectal cancer is on the decline because of that, because colonoscopy is becoming more popular, and we're getting the word out, and people are getting their polyps removed. Colonoscopy has become the dominant screening test over the last decade or more. This is a graph, a little bit dated, 2008, but it shows overall, that top line is any type of screening, and I'll go through the different types of screening, but any type of screening has been on the rise over the last decade or more, and actually that line probably touches the 60% line. In fact, in Missouri, it goes a little bit above the 60% line. The next line is colonoscopy, and you see that's taken off since 2000. In 2000, I don't know if you guys remember, Katie Couric, her husband got diagnosed, and that really helped put out the word about colonoscopy and colon cancer prevention. And then at the bottom here is a fecal occult blood test, which is just a little blood, a stool test that they can check for blood. This is in Missouri. This is obviously the map of the United States, and in Missouri, it's a little over 60% now. So we're right in there on that 61 to 62% rate of getting screened. That's what that is. It's colon cancer screening prevalence. So we're not where we need to be, and in fact, there's a big campaign that's starting this year, 80% by 2018, and that's the American College of Gastroenterology is making a big push to try to get 80% of the population that needs to be screened by 2018. So we're doing better in Missouri. What do patients say the reason for not getting colonoscopies? Awareness is a big reason. We're doing a better job of that. Lack of knowledge about the screening benefits. A big thing is fear or embarrassment. Sometimes time, certainly cost, and access to healthcare is another one. And this bottom line my doctor never talked to me about is actually getting better with electronic medical record, because it reminds us, the primary care physician, hey, listen, you don't have your colonoscopy yet, and there's a light that pops up or a little box that hasn't been checked, and so that has been one good thing about the electronic medical record. So that's getting better. But that was actually in the early 2000s one of the biggest lawsuits was physicians forgetting to tell their patients about colonoscopy. There's been, as far as ethnicity, all these are declining. And the top line is it's separated in male and female. Top line is African Americans. Then all races, and Caucasians are kind of superimposed right underneath all races there. Hispanics, Africans, and then Asian, Indian Asians, and Far East Asians. This is a polyp study that was done in February 2012, talking about the long-term benefits of colonoscopy. It's kind of surprising that it took that long to get a really good study in a great journal showing that polypectomy saves lives and prevents colon cancer. This is the graph basically that shows the general population up here that did not get an adenoma removed, did not get colonoscopy for colon cancer prevention, and down at the bottom is years followed. So they followed out for a little over 20 years actually. And along the left side there, it's cumulative colorectal cancer mortality or death from colorectal cancer. And without getting screened, there was 25 deaths in this cohort of patients. And the blue line there is patients that had colonoscopy and had polyps removed. And adenoma is another word for polyp. They had those polyps removed, and so you can see that it decreased it by almost 60%, about 56%. And actually, the 12th death from colon cancer from the population that had adenomas was actually at year 22. So it was really 11 deaths within that 20-year period. So it drastically reduces your chance of getting colon cancer. Whoops. So this is basically what I just said, 56% reduction in mortality and removal of adenomas versus the general population who did not get getting colonoscopy. So colonoscopy, removal of polyps, prevents death from colorectal cancer. What are the risk factors? These are just the general risk factors. Age, 90% of the cases occur above the age 50. That's why we chose that age. There's a slight male predominance, but not very much. It's pretty much even male to female, but there's a thought that testosterone may increase the rate just a little bit in males, and certainly, but it's very close to females are very close to males as far as the risk factors. And then race, African Americans have the highest rate of colon cancer, and the College of Gastroenterology recommends African Americans getting screened at age 45 and Caucasians at age 50. However, the insurance companies kind of dictate the final word there, and it basically puts everybody at age 50 for colon cancer screening. Hispanics and Asians are the lowest rates of colon cancer. This is a graph showing age-related colorectal cancer deaths. I'm going to highlight this because it's hard to read that bottom line. That's age 50 and that's age 70, and you can see the increase in the graph over that 20-year period, increased rate of colorectal cancer deaths. So it's very important to start early at age 50. If you have no polyps, and we'll talk about this a little bit later, if you have no polyps and you have no family history, then you don't get screened again until 60 and then 70. And if you have no polyps during that time period, the recommendations are not to further test for colon cancer. So at most 3 colonoscopies, but it's a drastic increase. And if you look up to age 80, which our life expectancy is growing, or is getting higher, age 80 it's about 3 times as high as age 50. So average risk colonoscopy, average risk for colon cancer is no personal history of adenoma, no personal history of colon cancer, and no family history of polyps or colon cancer, and they need to be screened at age 50. Increased risk, people that have family history of colon cancer or colon polyps, and then high risk is folks with ulcerative colitis or Crohn's disease, which are 2 chronic disorders, and then a couple of genetic disorders, familial adenomatous polyposis and hereditary non-polyposis colon cancer or Lynch syndrome. These occur at a younger age, and the folks are at high risk because they develop so many polyps. And this is just a graph showing kind of what I just pointed out, but sporadic colon cancers is a large majority of it, meaning it just happens. There's no reason why it happened, it just happened. It's a genetic mutation in the polyp, in the colon, and it develops a polyp, then colon cancer. Family history is about 15%, and then these polyposis syndromes I just mentioned are only 5%. So 2 big things I always hear is, when I diagnose somebody with colon cancer and they never had a colonoscopy is, I didn't have any symptoms, which, we know that it doesn't have symptoms now, and I don't have any family history of colon cancer. Well, family history of colon cancer is only 15% of those folks. They're certainly at high risk, but majority of people have no symptoms and they have no family history, and no logical reason to get colon cancer. It just happens. So it's important to get screened. What are the symptoms? I've talked about this a lot, but there are no symptoms. There is a possibility of having one or a combination of the following: change in bowel habits, cramping, abdominal pain, blood in the stool, blood in the toilet bowl, or unintentional weight loss. By the time these started to occur, the cat's out of the bag, and we're looking at late stages colon cancer, stage 3, 4, for the most part. There are some rare instances, but for the most part, it is asymptomatic. So don't count on symptoms. When we talk about prevention, there's primary prevention and secondary prevention. Secondary prevention is what we're talking about, colonoscopy and getting screened. But primary prevention is behavioral modifications, whether it's exercising or eliminating risk factors. When we talk about eliminating risk factors, we can talk about diet, or there's been proof that baby aspirin can help reduce the amount of polyps that you have, or the rate of polyp growth, which has been well known for several years, but that's one thing. But when we talk about diet, there's a lot of myths out there, and there's a lot of facts and a lot of studies ongoing about diet. And we know that the incidence of colon cancer varies globally. So like we talked about, Asians don't have much colon cancer. Well, is that because of their environment? Is that because of their diet? What do they do different that we do? Because we have the highest rate of colon cancer in the world. When you talk about somebody immigrating from Japan, let's say, a couple immigrates to California, they have children. What happens to their children? Do they have the same risk as the Japanese folks? They eat rice and a lot of fish and not very much red meat. They're not as obese as we are. So is it where they live, or is it what they're eating? That's the question. So it becomes, is it something that is environmental or not? And we found that the kids of immigrants actually adapt whatever country they're living in, because they get Americanized and they want to eat hamburgers and whatever. And so the thought is there's something environmental. And we're not talking about this kind of environmental stuff. We're talking about diet. And so when we talk about diet, these are some of the big things that come up. We eat a lot of red meat, a lot of steaks, hamburgers in this country, and they don't, let's say, I used Japan as an example. And so that could be something that relates to colon cancer. And so we found that in studies that high red meat intake equals high risk for colon cancer. And we think that it's carcinogens produced through when we grill and we increase the heat of the beef. It makes some carcinogens in there, and it's actually these polyaromatic hydrocarbons and heterocyclic amines, which are hard to say, and it's not important to know what they are, but just the fact that cooking steak on a grill is going to increase those hydrocarbons and cause increase the carcinogens, I guess. So then it becomes, how do you metabolize it? We know that when I give somebody a medication, if I gave everyone the same medication, they metabolize it differently. We're all treating blood pressure, let's say, but you're going to metabolize it different than she will. It may have the same outcome, it'll decrease your blood pressure, but there's a slight difference. That's why some people have allergies to medications and some don't, because the drug gets metabolized into an allergen, and then they have an allergic reaction to it. So the same thing with this. So when you have these hydrocarbons and heterocyclic amines, I may metabolize it into a toxin that is carcinogen that develops colon cancer, where Jen may eat it and she may not have any problems, and she metabolizes in a non-toxic thing, so she does not have an increased risk for red meat. So in the future, we'll have this genetic profile. Everybody have a genetic profile. And so we'll use a medication for an example. We'll have not a lisinopril that I give 100 patients. It'll be a lisinopril that's directly for you and a lisinopril for you, because you metabolize it different. We'll find out how you metabolize it, and we'll give you that medication. So then we may be able to find this for carcinogens like in red meat. And it'll be, and I don't think it's very far away. I mean, they're doing studies on it now, so. And I guarantee by the time I've retired and talking to my grandkids, they'll be like, you gave everybody the same medication? Why would you do that? It's barbaric,
Keller,
Yeah.
Question regarding genetics.
Mm-hmm.
I'm sure you're aware in breast cancer, we've been able to predict a specific genetic make or genes that are predictive of
Mm-hmm.
getting breast cancer. Where are we along that pipeline or pathway for colon cancer?
Right, not as far along as breast cancer. We do know what happens to the genetic loss. There's mutations in certain genes. We know those mutations, but we don't know who's going to get those mutations and why. And if it's diet related, for instance, then it'll come down to this, how we metabolize things. And we know that you're at increased risk for colon cancer, not because you have a family history or polyps, but because you're going to eat red meat, so you need to stop eating red meat because you metabolize into this. So as far as I know, right now the genetics are all pointing towards how we metabolize and the risk factors and how we can curb those. But it's not as far along as breast cancer. And so next we'll talk about fiber. Fiber, 40 years ago that we were told fiber decreases the risk for colon cancer. In fact, on our sheet we say decrease. It's like a standard little sign at the bottom that says increase your fiber intake. Well, a study came out in 2005 shows that in a pooled analysis, so a bunch of different studies of 700,000 people, showed that in 13 different studies, there's no protective value to fiber. Now that doesn't mean that the fiber-containing foods like broccoli and vegetables and fruits don't help protect, but its actual fiber doesn't do anything for us from colon cancer prevention. So if you're taking Metamucil to prevent colon cancer, then that's not helping the cause. But what about fruits and vegetables? So that's our next thing on the list. Fruits and vegetables, we have seen in studies that there is moderate protection, and we don't know the mechanism, but we know it's in the plant kingdom, and it's anti-mutagenic and carcinogenic. So there is a carcinogenic pathway that's altered, and there are several things out there from a fruit and vegetable standpoint that help prevent colon cancer. The most recent small study that I was reading is talking about quercetin and curcumin. Curcumin comes from ginger root, and it's also the pharmacological. We may have heard turmeric is a Indian spice. It's the pharmacological component of turmeric. So if you get turmeric, you're getting curcumin, and it comes in ginger root, and it's an anti-inflammatory, and it's been shown in small studies to help prevent polyps. Now, we know that polyps turn into colon cancer. There's no proof that it prevents colon cancer, but we know that it's the polyps a precursor, so naturally if you're preventing polyps, you're preventing colon cancer. This quercetin was seen in a decrease in polyposis syndrome, so that familial adenomatous polyposis where people make tons of polyps at a young age. Quercetin was shown to decrease the number of polyps. That's found in capers and a small amount in blueberries. Actually, raw capers is the highest, and then canned capers is second. It's about half as much quercetin. And then blueberries, I'm trying to think of other things that have it in it. Kale was another one. But these are fruits and vegetables and components of fruits and vegetables that we know help prevent polyps, that can help prevent colon cancer. So it's not actual fiber that is helping us, it's something else. And garlic is chemopreventive, and it helps prevent polyps as well. And it's not to say you go eat a bunch of garlic, you're never going to get a polyp. I don't want anybody to get that. It helps the cause, and it helps prevent the number of polyps, maybe. Calcium and vitamin D, I found this fascinating. There's a randomized control trial, which is the best kind of trial we get. So it means there's, let's say, 1,000 patients, and we split them into 500 and 500, and we randomly give 500 X and randomly give 500 Z. We don't know, nobody knows who's getting what, even the people who are doing the study. That's the best scientific study we can do. And so they did this with calcium and vitamin D, and they found with 1.2 grams or 1,200 milligrams of calcium carbonate, compared to the placebo. So somebody got calcium, somebody got a sugar pill. There was a 24% reduction in new polyps in those patients that took the calcium, which is really remarkable. And then vitamin D, they didn't see any change in cancer overall, but they did see a change and reduction in colon cancer with vitamin D. Selenium, another randomized control trial. This is looking at skin cancer, but they found that there's a 60% reduction in those patients for colon cancer. But there needs to be more studies looking at this. Micronutrients, so we're talking about vitamin A, C, and E. These are antioxidants that prevent oxidation of the DNA. Oxidation of the DNA causes mutations. Mutations cause cancer. So it makes sense to take antioxidants. Well, actually, the studies don't really show that for colon cancer. And in fact, folic acid epidemiological studies showed a positive effect to preventing polyps, but then when we did a randomized control trial, it actually showed that it increased adenomas, which is a little bit confusing. So I think definitely more studies need to be done on folic acid, and I'm not recommending you stop your folic acid if you're taking it, and it's certainly needed when you're certainly taking other medications that deplete your folic acid. But they found in Canada and the U.S. when they did an ecological study that actually rates of colon cancer increased when they added it to the food supply. So in our food supply, they add calcium, they add folic acid, and they've seen an increase in colon cancer since they've done that. So is that just kind of true and unrelated, meaning, yeah, true, they added it, and true, the increased rate in colon cancer, but they're not related? I don't know. But it's something to look at, and it was surprising. And I like to point out, this is not like in a pamphlet that they're doing over in Scott City. I mean, these are major New England Journal of Medicine, National Cancer Institute, JAMA, which is like the biggest medical journal we can do. Gastroenterology is our biggest, the gastrointestinal journal. And then the cancer epidemiological biomarkers, that was a study in Canada. I mean, so these are big-time journals that are very reputable. And then alcohol, alcohol in moderation is okay, but certainly in increased rates, it can increase the rate of colon cancer. And actually, I just learned this preparing for this talk, but beer drinking actually increases the risk for rectal cancer, they think. They've seen a prevalence for that. So, and then cigarette smoking, we all know, increases the risk for all cancers, not just colon cancer. And when I see a patient in the clinic, or we have direct access where I meet them for the first time in the endoscopy suite to do a colonoscopy, and they've smoked for any significant amount of time, I can guarantee that they have polyps. I have no doubt that I'm going to be removing polyps. It's just that common. And I tell them beforehand, like, you're going to have a polyp, I'm sure of it. So when we talk about lifestyle, we're talking about obesity. We're at the highest rate of colon cancer in the world, and we're the most obese country in the world. I think that's not a coincidence. One of the questions is it the amount of food we eat versus the type of food? I think it's a combination of the two. Obese women, there's a 50% increase in colon cancer, and obese men, 80% increase. And that's more related to abdominal obesity. When men carry weight, they carry this abdominal obesity. And that is also found to increase your risk for diabetes and insulin resistance, and it also increases the risk for colon cancer. Physical activity, we know it protects against colon cancer. We don't know how. So all I can say is go exercise. Inactivity could explain, we've been more inactive. I would say over the last 5 to 10 years, we're getting more active. But over the last 20 years, we've been more inactive than ever. And in industrialized countries, not just the United States, and there's been increased rates. Is that a coincidence? We don't know, but we do know that exercising prevents cardiovascular health, and I don't think it'll be a bad thing for colon cancer either. So these are what I would consider practical, modifiable, meaning things you can control, evidence-based, great journals that have studied this, recommendations that I would take out of all that we just talked about. A sensible diet, what does that mean? I mean, I think, fruits, vegetables, limit red meat to less than 2 servings a week. I, honestly have a hard time. I eat red meat any chance I get, but I need to not do that. And so I would say over the last 2 or 3 years, I've decreased the amount of red meat based on these studies that we're seeing. So that's a sensible diet. We all know what that is, and also portion size is a big thing. Avoid obesity, the BMI less than 26, which is, pretty sporty. I think I'm like maybe a 24 or something like that. So obesity is considered 29 or 30. And morbid obesity, I think, is 35 or greater. So we'd like to stay with our BMI below 26, and I think the doctor, every time you go to the doctor, they always calculate it, or they can calculate it for you if you need to find out. Exercise 30 minutes a day, and then consider calcium and vitamin D, 1.2 grams or 1,200 milligrams supplement. That was a really well done study that showed 24% decrease in polyps. We know polyps cause colon cancer. I think it is really worth taking a calcium supplement every day. And then limit alcohol consumption. And then, more importantly than anything, is participate in screening. If you don't do any of that stuff, your risk starts increasing at age 50, and you start developing polyps at age 50. So more important than all that, you're not going to take calcium and prevent colon cancer. It's just, it's going to help reduce the number of polyps by 24%. The thing that prevents colon cancer is getting screened at the appropriate time. Oh, sorry. Pardon?
Dairy products.
As far as colon cancer, I haven't seen any studies that show it. Now, certainly dairy products can cause issues with the gut, and lactose intolerance is a higher prevalence as you age. But I haven't seen any studies that show it increase your rate of colon cancer.
The calcium in the dairy products still?
Gotcha. Yeah, I mean, it should, but I think I wouldn't rely on it from a standpoint of calcium intake. They say that the amount of calcium we have from our bone standpoint, we've already intake from age 15 or 20. But as far as your daily amount of calcium, I would rely more on a multivitamin or a calcium supplement, because you know exactly how much you're getting. I mean, you can drink as much milk as you want, but I think you know exactly how much you're getting when you take that supplement. I would rely on that more. But some folks have trouble with their bowels and things with lactose. I thought that's where you were going with that. But that was a good question. So, secondary prevention is what we've talked about. Early tumor and polyp detection. So we talked about polyps a bunch. What are they? It's just like a mole. It's a growth of tissue inside the colon. This is a great picture of a pretty good-sized polyp. This pointer doesn't show up on the screen, but this is a big stalk here, and with it's kind of like a mushroom, basically. That's I've seen those actually be a colon cancer, but that's a decent-sized polyp. They're typically the ones we see at age 50 and things like that. Can be that size, but usually smaller than that. 30 to 50% of the general public have polyps. Not all of those are adenomas. There's different types of polyps. There's hyperplastic polyps, which don't really mean anything. They have a very low risk for cancer potential. Adenomatous polyps, or adenomas, account for 90% of colon cancers, and that's what we're looking for. Sessile serrated adenomas are flat, very camouflaged, if you will, polyps that are very hard to see from time to time, and they occur in the right colon. The ones that occur in the right colon can develop into colon cancer. And we've actually only known about this for probably about 10 years. So a lot of times we'd see them and biopsy them, they'd call them hyperplastic polyps. And then over time we've realized that these are actually turning into colon cancers. This is a picture of a polyp here, and this is one of those flat, sessile, serrated polyps that is very camouflaged. Those are two ridges there, are folds, and this is the polyp here. And I don't know, with that light above it, you may not be able to see it, but there's some vessels right here. They kind of come into the polyp, and then it just shuts off. You can't see the vessel anymore. And the same thing over on this side. I think that light's probably you're not able to see it as well. But it's very camouflaged, so it's hard to see. But that's a sessile serrated adenoma in the right colon that was removed. And there it is under different wavelengths. Under our scopes, we can do different wavelengths. And so that's under kind of like a blue light, if you will. You can see it a little more. Can y'all see that a little better? So that's the same polyp. Here's a different one. This one's a little more obvious, but still flat and can be hard to see at times. And that's actually, this one was actually an adenoma, not a serrated adenoma. And the difference is just in the pathology that they see under a microscope. And these are the stages of adenoma to cancer. Stage 1, stage 0, which is polyp, and it's just this layer of the colon, and you take that out, and then no progression. This is stage 1 colon cancer, where you have this green thing is a lymph node. The lymph node is not involved, but the lymph duct is actually involved there. Blood vessels start to get involved in stage 2. Stage 3, you have local involvement, which is this is a lymph node that's involved. This is what Ronald Reagan had. And then stage 4. So incidentally, Ronald Reagan got diagnosed after having it for about a year, so he probably would have been in stage 1 if they would have done a full colonoscopy at that time. But he lived 20 years later and died of something else. And that was in the 80s. So we have good treatment for colon cancer. We just try to prevent it because it's very preventable. This happens over about a 10 to 15 year period. This is a little pathway showing normal. That's a normal colon. That's a massive polyp. And then this colon cancer. This is the genetic, I don't want to get into too much scientific stuff, but this is the gene that gets lost, APC gene. From normal epithelium, you lose the gene, then it comes into hyperproliferation. It just means a bunch of cells grow. And then it's an early adenoma. This is a late adenoma. So early adenoma is very small. So early adenoma, then you have something called a KRAS mutation, which is not important for you guys, but I think it's important to show the timeline here. Intermediate adenoma, you lose a chromosome, and late adenoma. And then this is another gene that gets lost, and you turn into colon cancer. So a lot of things have to happen for it to occur. And this is the ideal screening period. We don't want to screen people at age 30 because they're going to have normal epithelium. They lose the APC gene, they start having hyperproliferation in their 40s, and then this is all general, but around 50 you start developing polyps. And so the ideal screening area is early adenoma detection to late adenoma detection. So this area here is the time to get a colonoscopy. And so that's kind of how that timeline goes, and that's why we chose age 50, and because we know the early adenomas start popping up in the end. That makes sense? It is the most ideal cancer for screening because it's common, it occurs commonly, and there's a precursor lesion, and it's slow growing. And we have several tests that will help us prevent colon cancer. So let's talk about the screening tests, surveillance, and diagnostic evaluation. These are the different definitions. Screening is the very first colonoscopy where we're looking. You don't have any family history. You don't have a history of polyps. We're looking for the polyps. Neoplasia is another word for polyps.
Explain what colitis is.
Colitis? Colitis is an irritation of the lining of the colon. So if you have, and it's more of a pathology term, meaning that you biopsy it and you take it and they'll say there's colitis here. But you can see it when you go in. There's ulcerative colitis, Crohn's colitis, infectious colitis, colitis secondary to medications, ischemic colitis. There's tons of different kinds of colitis. They typically don't involve colon cancer unless they're chronic colitis, and it happens. You're not getting treated, and you have years of it. And why is that? Because you have a big turnover of cells in the colon, and it looks like. You ever seen like road rash or somebody gets a bad carpet burn? It's kind of like that with little small ulcers in the colon. And the cells are constantly turning over to try to heal itself, and they slough off and you turn over more cells, and you're growing so there's a lot of proliferation of cells. Well, when you have that much cell making going on, there's that much more risk of a mutation. So if, let's say you turn over cells 1,000 times a day, well, if you have colitis, you're doing like 1,000,000 times a day. So you have that much more chance of developing a mutation in that cell. And that's how colon cancer occurs with Crohn's or ulcerative colitis. But colitis is kind of a generic term, but it refers to small ulcers in the colon, and it can be in different areas of the colon or the whole colon. And it's treatable, but that's kind of it. So surveillance is a different, when you're looking, you have a prior adenoma, or if you have chronic colitis, inflammatory bowel disease like ulcerative colitis, or you had a cancer in the past. These are definitions. Insurance companies care a lot about these definitions. Each time we do one of these, we're doing the same thing. We're going in and looking for polyps or potential colon cancer. And then diagnostic evaluation means you may be having bleeding, and so we're going in to diagnose you why you're having bleeding. That's what that means. We've talked about this, and it improves survival. Stage 2, if you diagnose with stage 2 colon cancer, you have a 90% 5-year survival rate, which is excellent. Stage 3, it's roughly around 70%. And in stage 4, it's about 10% 5-year survival rate. And these numbers are getting better. This is average risk guidelines, 50 years old, no family history. These are 3 of the options. Get your stool tested for blood in it, which that's more of not a polyp detection test, that's for a colon cancer detection test. And there's a difference there, but this is what the CMS and this is what the United States Protective Task Force, this is what they consider in the screening guidelines. But there is a difference between a colonoscopy and a fecal occult blood. Fecal occult blood is not looking for polyps, it's looking for cancer.
How do they tell the difference between bleeding from the hemorrhoid as opposed to from the cancer?
You can't. Right. It's not a very specific test.
Along with that, then, because I've heard then that dark blood is usually cancerous, but that's not true.
Mm-mm.
If somebody has cancer,
No.
that's your blood.
Not necessarily, no. A lot of times it doesn't bleed, but so then colonoscopy, that's the standard of medical care. If you have no polyps, then you get 10 years for your next one. If you have an adenoma, it depends on a polyp, then it depends. You get 3 to 5 years. It depends on the size and how many you have. And then with flexible sigmoidoscopy, meaning you just go to the left side and you have a polyp, then you have to turn around and do a colonoscopy at a later date. And if it's negative, then you get 5 years. And this is National Screening Guidelines. First degree relative is a parent, child, or sibling with colorectal cancer. If they get diagnosed with that below the age of 60, then you need to get a colonoscopy 10 years before them. So, beginning at age 40. So, if they got diagnosed at age 53, let's say your father got diagnosed at age 53 for colon cancer, then you need to start at 43. Because the reason we do that is because we know it's a slow-growing cancer, and the family member that got diagnosed at 53 likely had it for several years, a polyp that turned into a colon cancer. So in your lineage, you probably need to get 10 years before that, and you'll get a precancerous lesion based on what I showed you earlier with the adenomas not turning into colon cancer. So it just pushes you up 10 years from when they were diagnosed, and to help catch it. And then you don't get 10-year window, you only get 5-year window, because your family has been shown to have an increased risk. So what are the screening tests? There's tests that detect cancer, and there's tests that detect adenomas. So there's fecal occult blood tests, which we just talked about, and that's just when they check, your primary care doctor will check you for blood in your stool. And that's checking for cancer. There's stool DNA test, which last year got approved by CMS as a screening modality, but that's again checking for colon cancer, not colon polyps. And then there's a fecal immunochemistry test, or FIT test, you'll hear that be called. All these are to try to detect cancer, not polyps. These are to detect polyps or cancer. A flexible sigmoidoscopy, if that's a negative test, then you get it every 5 years. A colonoscopy is every 10 years. CT colonography is a CAT scan, where they look into your, we'll talk about it in a second, but they look at your colon for polyps, and that's every 5 years. And then a barium enema, which is an outdated test, where they inject barium into your bottom and look for shadows of polyps, and that's every 5 years. And those are polyp detecting tests. So this is we always hear about the prep and the nightmare of drinking all that stuff and cleaning you out. And this is what it used to look like. This is a bottle, a 4-liter bottle that you have to drink. Used to, we'd do it all at one time at night, and you have a little old lady that's like 90 pounds that was trying to put down 4 liters. It just wasn't fair. But then we split it to 2 liters at night and 2 liters in the morning. And then we came out with this small volume prep, and then there's multiple small volume preps out there. This is just one I chose. But it's a 16-ounce cup with a 6-ounce bottle. You pour the 6-ounce bottle into the cup, then you fill the water to the line here, and you drink it. So it's basically like a bottled water in volume of the prep. And it doesn't, it's not like a margarita or something. It doesn't taste great, but it does the job, And then after that, you drink 2 more cups of water or Gatorade, whatever you want. And then you wake up in the morning and you do the other 6-ounce bottle. So it's a lot less volume. They can't get it to taste good. I don't know why, but it doesn't taste good. But they've got the volume way down from this 4-liter prep here. when we ask you to drink that prep, we do that for flexible sigmoidoscopies, for colonoscopies, for CT colonographies, any polyp detection test. You need to drink a prep so we can see in there, because otherwise there's stool in there and we can't see the polyps. And they can be flat, like I showed you earlier, those camouflage ones. When we talk about flexible sigmoidoscopy, the benefits are it's quick. You don't necessarily have to have sedation. We still usually in this country sedate people for flexible sigmoidoscopies. You don't have to though. There's not much in the way of bowel prep. Sometimes we'll do a enema, but it doesn't clean out as well as a prep. So we usually just give people bowel preps, and it also detects polyps. So it is a good test for testing the left side of the colon. The limitations is it only views a third of the colon. This is what happened to Ronald Reagan. You do have to have a bowel prep. There's always a risk of bowel perforation or bleeding or anything like that. That's just part of it. And then if you have a polyp in there, then you got to turn around the next day or later that next week and drink the prep again and have a full colonoscopy. And if it's negative though, you can repeat it every 5 years. And again, like, you don't have to have sedation, and that's a limitation sometimes because people want to move and things like that. So sometimes no sedation is a limitation. So colonoscopy, the benefits are it examines the whole colon. It detects and removes polyps. Very well insurance covered. It's the gold standard, so all insurances cover colonoscopy for the most part. And then it's required, if any of those tests that we're talking about or we've already talked about are positive, then you're required to get a colonoscopy. The limitations is it's a full bowel prep. You're drinking that 16 ounces of stuff. You do have to have sedation. A lot of people don't see that as a limitation. They see that as a good thing. But and then there's always a risk of bowel perforation or a bleed. That rarely occurs. National numbers are like 1 in 1,000, but our numbers here are a lot less than that. So that's a rare occurrence that would happen. So back to the anatomy here. This is what a flexible sigmoidoscopy does. That black line there. Ronald Reagan kept having bleeding. They thought it was hemorrhoids. He had a couple polyps here. They thought it was due to that. This is a full colonoscopy there where the green line is. So they removed those polyps, and then he had another one. They couldn't figure it out. They thought it had hemorrhoids, and then he bled some more. And then finally, a year later, they did a full colonoscopy, which is the green line. They found a colon cancer on the opposite side of the colon. Like immediately, I had one of my attendings was at Walter Reed, and during this time, and he was telling me, this is one of the guys that taught me in fellowship for GI, and he said literally within the next 3 weeks, like all these senators and congressmen and women came in to get their colonoscopy because they'd already had their flex sig, and now that he got diagnosed, they just kind of flooded him back in to get their full colonoscopy. And that really did change the whole dynamic of colon cancer screening. So 40%, remember 30% in the ascending and 10% across the transverse, so 40% of colorectal cancers don't get picked up by flexible sigmoidoscopy. CT colonography is a CAT scan that examines the entire colon. There's no sedation. Sometimes people feel that is not a benefit, and it's fairly quick and minimally invasive. This is a CAT scan where you have to drink a full bowel prep, but they put a hose in your bottom and blow air in there to kind of separate the walls. And I mean, I would want to be sedated if that was happening to me. But and then they look for polyps, and it's actually really impressive images. They don't see polyps less than 6 millimeters. The studies show that they're not as good at picking up less than 6 millimeter polyps. I had a advanced adenoma last week that was 6 millimeters in size. So to think that would be missed is a little bit concerning to me. But they're making headway with this, but it's not there yet. If you find a polyp, then you have to turn around at a later date and drink another prep. So small polyps can be missed, small cancers can be missed, and those flat polyps that are camouflaged that I showed you earlier will not be picked up on a CT colonography, like this polyp here. Fecal Occult blood test, it's low cost, non-invasive. You're not getting a colonoscopy with this. And there's no bowel prep, but it does detect polyps, it misses some colon cancers. There's false positives with the hemorrhoids, like you mentioned. If you eat steak beforehand or you take iron, this can make false positives. And if it is positive, then you're going to need a colonoscopy to begin with, to follow it. Fecal immunochemistry test is a little bit more specific than fecal occult blood. It has the same benefits. The limitation is it, again, doesn't detect polyps. And if it's positive, it needs a colonoscopy. So you remember that big polyp that I showed you on the, that's the kind of polyp that this test was made for. So these little flat ones or these adenomas that are small, 6 millimeters, that we take out via colonoscopy, this test doesn't pick those up. It picks up the more advanced adenomas or already cancer. This is fecal DNA. Similar benefits, limitations are similar as well. There's recent study looking at FIT test, the fecal immunochemistry test, and the DNA test. This test detects hemoglobin, which is a protein in our blood. It detects the mutations in those big polyps that we talked about, and also from colon cancer. It's more accurate than FIT tests in picking up those large advanced adenomas. It's actually less accurate than FIT tests at ruling out advanced adenomas or colon cancers. This was a study that was done in 2012 as well about colonoscopy versus fecal immunochemistry test. And the conclusions were that they both found colon cancers, which is not overly surprising. The FIT subjects, the people that got their stool tested for blood, were more likely to get screened than people that wanted to get a colonoscopy. I mean, if you got told, you get a colonoscopy or you get your stool tested, there's going to be a larger group just saying they're going to get their stool tested because they don't want to go through drinking the prep and doing the colonoscopy. These are the numbers that are important, though. So out of this study, only 231, or a little less than 1%, found advanced adenomas, which is those big polyps with a stalk on it, where colonoscopy found 514, which was 2% of that population, so twice as many. And then we're talking about the big polyps. And then adenomas, which are the smaller polyps that weren't advanced, FIT picked up 119, where colonoscopy picked up 1,100. I mean, so that is a huge difference as far as the difference between those two tests. The best test is the test that gets done, but the most complete test is the colonoscopy. So the treatment is a whole nother lecture. I could spend another hour on that, so we're not going to do that. But it depends on the stage and location of the cancer. I've had what it looked like an advanced adenoma. I took the polyp out and it ended up coming back as a colon cancer, but all the margins were clear, and so we had a cure of colon cancer in the GI lab that didn't require anything but just a regular polypectomy. If it's advanced, then it's a large obstructing lesion, then it requires surgery and chemotherapy and radiation. So it varies just on where it is in the stage. So in summary, we have average risk, should be age 50, African Americans is age 45. It's a highly curable colon cancer if caught early. 90% of people at stage 2, 5-year survival rate. The take-home message again, it is preventable because we're looking for precancer lesions, and those are polyps and colon cancer, and those do not cause symptoms. I mean, if you go home, if you talk to anybody about this, these first two things are the things to tell them about. Like if you go home and tell your family member you have somebody that you know needs a colonoscopy, these first two points are huge because it just doesn't cause symptoms. And every week I have somebody, unfortunately, that says they didn't have any. I won't have any symptoms, and we know that. So hopefully we can spread the word. The age to start is age 50 unless you have family history of colon cancer, and then get screened. So this is something that we do here at Southeast. It's direct access colonoscopy. What that means is you can you don't have to be seen in the office to get the colonoscopy. You kind of avoid the office copay and the office visit. You don't have to take two days off of work to get your colonoscopy. You just call this number, and we have some handouts too that you can call. Has a number on there, and the nurse will talk to you about your risk and other health problems, your medications, and get everything squared away. And then we order the bowel prep, you pick it up, and then you just you take the prep as instructed, and you meet us in the GI lab. It makes it easier on you guys, and you can avoid the copay as well. So that's it. Yeah.
The use of probiotics, do they have a role in reducing the risk?
Yeah, not that we know just yet, but it's certainly they're good for us, and we're mapping the genome of the bacteria in our gut currently, and we should be almost be done with that, and running studies on it to find out which bacteria are good. So probiotics are basically good bacteria. It comes in yogurt. You can get it pills that have it over the counter. You can get prescription for it, and so there's a lot of use for them. The studies are ongoing right now, but there's no proven benefit just yet. But I wouldn't be surprised if it does come out that way. Initially, everybody kind of thumbed their nose at probiotics and the thought of taking it, but I think studies over time have showed that they're good for us. And I just tell people the cheapest thing is to eat yogurt. You have 2 good cultures in there. We don't know which ones are good for us, and a lot of these over-the-counter probiotics can get expensive. And so we know the 2 in yogurt are good for you, so just eat those if you like yogurt. Any other questions?
Yeah. My mother had colon cancer, so I was screened at age 38. I'm due very soon.
Okay.
For my next colonoscopy.
All right, fine.
My son was diagnosed in 8th grade with ulcerative colitis.
Okay.
So he's been on medication, but has stopped that in the last 2 years.
Mhm.
So, what should I? What's
him?
the recommendation for him?
Right. So.
The history.
Right, so it goes back to the colitis that we talked about. So with ulcerative colitis, the guidelines are a little bit different. Usually they'll have a colonoscopy early on to get diagnosed and things of that nature. Then you're on medications chronically. Depending on their symptoms, especially if they're young, you can come off medications, but there will be flares and things like that. But the guidelines say at diagnosis, then 8 years later, and then every 2 years after that.
So he did come off the medication because
Yeah.
he stopped having the flares.
Yeah.
So basically 8 years, and then every 2 years after that, if they find a polyp? Or
No, it's just every 2 years
2
after that,
years,
yeah.
Okay.
Because he has a lot more cell turnover, and so there's a lot more chance for mutation. And then, the family history, and it's a secondary family member. It would be his grandmother, right, that had colitis. So that wouldn't necessarily weigh into it as much, but he'd be getting screened so often. How old was he when he diagnosed?
He was 8th grade, so what is that, 14?
Yeah.
18
Yeah.
pounds. And I had a polyp on my first colonoscopy.
Uh-huh.
It was not cancerous.
Okay.
So,
Yeah, so he should get it at 22.
okay. Thank you.
Yeah. Any other questions? True, false questions? Or?
If someone comes in for direct access
Mhm.
during your H&P, they have symptoms, then they can
Right.
go to something besides screening, correct?
Correct, yeah.
I
If
just
they,
want to make that clear that if you
Right.
have symptoms.
right. So that goes back to the definition of screening, surveillance, and diagnostic tests. And everybody's insurance is different, and it used to be that you could kind of memorize what everybody was doing, but over the last 4 years, like I tell patients, I don't even want to even try to learn it because it changes. It's changed since I started this talk about an hour ago. So the guidelines for the most part is if you screen, you have no symptoms, they consider that a screening, and most insurances covered 100%. If you have symptoms, rectal bleeding or something of that nature, then that changes to a diagnostic test, and now we're going for a diagnosis, trying to figure out why you're having bleeding. And they consider that, and most insurances cover 80% of that. And then the other 20% goes back on if you've had your deductible and then all that stuff. So.
What causes stoma to die?
Causes a stoma to die? like an ostomy, usually lack of blood flow. You know, usually that will happen. Sometimes you can get little clots at the end there. I mean, it just depends. A lot of different things can cause that. A lot of other comorbidities, and if they have diabetes and things, that could, you know, lend them to be a little less able to heal right there, and clot formation, things like that. But that could do it. But you know, I have another specific case, but there's a list as long as my arm that could cause it.
Does it happen often?
It happens. I don't know the percentages of that, but it can happen, and that's certainly one of the risks. I've seen it multiple times, so yeah. Any other questions? Yeah. Uh-huh.
And I've had surgery for hemorrhoids.
Mm-hmm.
You know, I still have them, but I bleed a lot.
Yeah.
It's always like that.
Right. So it's hard. So in that situation, when we're talking about screening and trying to delineate screening from surveillance and diagnostic.
I've had colonoscopies.
Yeah.
For 5 years. I've had an aunt and uncle both died of colon cancer.
Gotcha.
My mother has colon
Gotcha.
problems. My sister has Crohn's disease.
Yeah. So you got it all right.
And like the last time I had a precancerous polyp removed.
Yeah.
But I still bleed.
Right. So
I
what?
have
What?
colonoscopy all the time.
Right. So what I tell folks, I mean, there's no way to delineate the two. But like from a standpoint, if you had a colonoscopy last year and you came into the office, what I would tell you is, has it, you know, what's your baseline bleeding? I mean, what's been happening over the last several years as far as your bleeding goes, and has that increased? If you had a colonoscopy last year, let's say, I would be a little less concerned about a colon cancer because it is a slow-growing cancer, and I would focus more in on it. But if it's been 3 or 4 years, then you may be warranted to do a scope if that bleeding has increased from your baseline bleeding. Right. Yeah. There's no great science to it, but I think that's the best way. If there's been a change, then it may warrant an evaluation if you hadn't had one recently.
There's a change.
Right, if there's a change in the amount or things of that nature. Does that help?
Yes.
Yeah.
Because the bleeding is like, you know,
Right.
after
right.
movement and then it
Yeah.
bleeds, so.
Well, the other thing is, like, from the standpoint of people that have chronic bleeding. Let's say you've had bleeding since you had kids, and you had your last kid at age 40, and it's been the same all the way through, and now it's time for your screening colonoscopy at age 50. Would you have bleeding? Yeah, well, I've had it since I was 40 when I had my kid. So, you know, I can't control what the insurance company's going to say, but what I document, I try to be document as much as I can to help the patient out and just say, you know, reports rectal bleeding. It's been chronic since they had their kid 12 years ago. It has not changed. There's been no change in bowel habits. You know, this is a screening colonoscopy for colon cancer screening. I can't control. I document as hard as I can that this is a chronic problem you've had for 12 years, and if that was a symptom of colon cancer, it would have already presented itself, and then called a screening. And then, you know, they may change it, they may not, and I bet it changes by provider. They may, you know, each provider has their own attitude. So, all right, any more? All right, well, thanks for coming out.